am going to give a perspective of a county, of what we're like everyone else here, be it state. We like to think we're the 14th largest state, but in terms of San Diego County, small or large, we have the same issues. And we're tackling our issues in San Diego, which we call Live Well San Diego, as our template for an integrated agency that I have the privilege of being the director for 5,700 employees, $2 billion annually, for all the health and human service programs. And you can see them listed. And a colleague of mine, Carrie Hoff, who's here from the agency team, and I are attempting to do some of the things we've been talking about since noon today. So I think you'll see now how these pieces perhaps come together in a geographical area. And you saw a slide about San Diego, this one, and it was reminding you that you need to exercise right after this event over to the drinks. And but really what this was being queued up for is sunny San Diego. People think you got no problems. You got great people, great weather. Really, you got no problems. And we are as broken and challenged as any other jurisdiction throughout this country. We are become known, not just in San Diego, but in great California and other states as the land of no pain, no gain to no escalator, no exercise. That's a joke. To how we also go and celebrate how we eat. This is at our Del Mar Fair, our county fair, to illustrate just a little tongue-in-cheek, but something not so sweet of what's happening as a community, because much of what I'm going to talk about is the hotbed right now. You're just not too far from the Capitol of what we're talking about in terms of the implementation of the Affordable Care Act. And California is leading that charge of great change. And part of it is what we have online is lives. So we have, you know, the statistic that a child born today has a shorter life expectancy than those of us in this room. But in San Diego, we have 1/3 of all of our 5th, 7th, and 9th graders that are overweight or obese. And 80% of that population will have a chronic condition, diabetes, by the time they're 18. So it has an economic imperative to the business community of winning on this issue of health and wellness. Now, why this is important is interoperability is crucial for us as a vehicle to make and improve the services, which I'll talk about. This is what we see in all our communities, right? Today, it's 18% of the GDP, nearly, for healthcare. By year 2020, it's expected to go to 20%. So what's on the rise is the cost, if we make no change. But no one seems to be happy when I talked about in the healthcare arena space. We've talked a lot about social services, but in the health arena has the same complexities and challenges. We have disconnects, and we have rising costs, and our quality of care indicators are not where they need to be. And this is the grim statistic for us, is that in San Diego, we have just 4 chronic conditions that contribute to over 50% of all deaths in our region. We call this, by the way, 3 for 50, and I'll show you a slide in a minute. It's true in every one of your communities. It's true in the state. It is a World Health Organization definition. And so why is this important, this 3 for 50? Because this is an easy drink conversation after this talk, because you're only going to remember 2 or 3 things. So 3 for 50 is 1. 3 behaviors that cause 4 chronic conditions that contribute over 50% of all deaths. But there's a 4th number. And the 4th number is that in San Diego alone, those 4 chronic conditions, we did a cost estimate. Just in direct medical care expenditures, those 4 diseases were $4 billion in 2007. Last year, the CDC, the Centers for Disease Control and Prevention, estimated $1.2 trillion for those 4 chronic conditions. And the 4 chronic conditions, by the way, is heart disease, it's cancer, it's diabetes, and respiratory illnesses like asthma. You know what the three behaviors are, hopefully. Lack of exercise, poor nutrition, and smoking. So those three behaviors attribute to those four chronic conditions that direct to over 50% of all deaths in every one of our communities. In those four chronic conditions, 3/4 of that is lifestyle-based, meaning only 1/4 is genetic-based. So here is a significant economic imperative, but a very significant issue for us of how do we improve the health and wellness and safety of our regions. And the federal government, in fact, when Rick was there in CMS, Donald Berwick led the charge on something called the triple aim. But in essence, it's about population-based improvements. How do we make large-scale population improvements? The judge, the honor, talked about we have some 50,000 kids in our dependency system. We have 5,200 in San Diego. Large population. How do we improve the health status and the safety of those 50,000 children? It's a large population-based improvement. How do we ensure we improve quality? And we have to be talking about the issue of cost because it's not sustainable. So when you look at these things, it's pretty challenging to achieve both quality improvements, lowering costs, and population-based. But I'm here to tell you that it's happening. And we're demonstrating that we can do these things here in California and throughout parts of the country. What the Stewards of Change has been facilitating in conversations with others of this mindset. So why this 3 for 50 was important is, and I know there's electeds and representatives for electeds, but I report to a board, County Board of Supervisors, so I had to keep it simple because this is complex. This is something that electeds get. This 3 for 50, both if you talk to chambers of commerce in the business community, to faith congregation leaders that are saying, why is their congregations withering away? To schools are talking about why we have high number of kids being absent. It's not only the issue of truancy, it's the issue that they're sick. So we've been looking at all the different sectors and saying, how do we really create this stewards of change concept in our community? And this is where we came up with our 10-year plan. It's not insignificant. We're spending $50 billion over 10 years to improve the health, the safety, and what we call thriving, or the economic vitality, of 3.2 million residents in San Diego. That's just the County of San Diego's budget. And it's beyond just my budget. It's the other county departments. Because what I'm going to describe to you is not the Health and Human Service Agency's plan, but the County of San Diego's plan. And we know that we have to achieve both health, safety, and thriving, because in the presence of violence, you can't achieve health. So we're looking at these multi-strategy approaches, and I'm just going to focus for the time that we have on the health aspect, because that's what Daniel asked me to talk about, which we call building better health. And we look at it, again, trying to keep this simple, because God knows it is very complex of what we do. From all across our programs, how do we keep it simple? And for us, there were 4 things we had to do if we were going to improve building better health. And that was looking at our service delivery system, which I'm really going to speak to talking about positive, healthy choices. How do you really create education? How do you create accountability for adults? How do you help a population make the better choices for themselves? We don't believe in big government in San Diego, so we won't take your chunky monkey ice cream away. We won't take your toys away. We won't take big gulps away. But how do we take the 260,000 people we have on CalFresh, i.e. food stamps, and introduce health education to people that come in? Or how do we deal with the 650,000 school-age children we have about healthy choices? So we're about making positive choices. So we're spending a lot of time on that, and I'm happy to talk about that for questions. And then the issue of policies. How do we build out sidewalks? How do we work with other jurisdictions? Much of what we've been talking about today has been county and state and fed. But reality is we have rural towns. We have neighborhoods. Where this is at, where the action's at, is in census tracts. It's in neighborhoods. It's in communities. It's in cities with counties. So we have the other imperative, how do we connect with established neighborhood groups on policies that matter to them. So we do a lot of resident leadership academies, trying to enable the citizenship to be aware and understand what the issues are in their community. Perhaps much of who's in here is organizations, but we also need to have the voice of these resident leaders who need to be educated about the importance of interoperability, the importance of we do, of how these pieces connect. Because you can imagine how daunting this is when you begin to talk to lay people who are trying to raise a family or trying to be taking care of an elderly parent or grandparent. These services, they're living firsthand. And so they can be the first testimonial, as we talk about person-centric, of how it's working and how it's not. So looking at those policies, working with cities and communities are very important. And then the last one we call changing culture from within. I love the challenge that Richard put out because we have to walk the talk. So if we're in San Diego, when we talk about the issue of wellness, we do worksite wellness for 16,000 county employees. I'm waiting for the federal government, for the Office of Personnel Management, to do that for their few million federal employees on employee wellness. I'm still working on that. But we have to do that at our state. I am proud of our state here in California. They are pursuing worksite wellness. But this is something that's important for the business community. If we in the government space, nonprofit space, need to get the credibility with the business, by the way, who generate the revenue to pay for government and nonprofit, we need to show that we're going to do the same in terms of fixing and improving ourselves in our own health and wellness, in terms of managing costs and to being more productive as employees. So that's our really four-prong approach, and I'm going to talk about service delivery, because much of what the focus of these 3 days is service delivery enhancements. And this is just to illustrate much of what we talked about. We have a lot of dedicated people, whether it's nurses and social workers and physicians, and even the administrators. We're all trying to do good for the Teds and the Janes of the world. And we all have pieces of what they need. And so really what we're aiming at, or what we're trying to achieve, is this culture change, saying, well, I know what Ted may need in different aspects, but how do we move the service delivery system to say, we now know what Ted needs? Now, I know some may think this is a little bit pie in the sky, and this is, again, what we're attempting to achieve. But let me illustrate with real case. And this is Donald Ryan. He is one of 180,000 people with a disability, a senior or a disability or a veteran that we have in San Diego. We have them all in our communities. Donald Ryan happens to be a 78-year-old veteran who has congestive heart failure. You can see, read on the bottom, Don, who's still alive. His wish is to sleep more in his own bed than a hospital bed. You see, he continues to get readmitted because there is a disconnect in how our services are arranged. And so we attempted back in 2009 to work with a Baldrige Award-winning hospital, by the way, Sharp Memorial Hospital, terrific hospital in San Diego, but had a 25% hospital readmission rate for people like Donald Ryan, because they kept doing it the same way they knew how. And their information systems only are in the walls of the hospital, but worse is they weren't even thinking about how it connects with the community. So we said, what if we paired up our Department of Aging, which we call Aging Independent Services, who live in the community and work in the community and work with people like Donald in his home, and who also work side by side with community nonprofit agencies. What if we worked with your care team, your discharge planners, your physicians? Could we perhaps look at a different model? Just let's test it. Let's see. And so we attempted to create this alignment, and the tools, NEAM standards, and were all still being discussed. But it speaks to what Rick said. It's really the people, not the technology. The technology is there. And so we created this alignment, even the way that we looked at our public health nurses, turning them into more of these care coaches, working with discharge planners who they've never met before, And I would venture and say we've had a conference in San Diego where we brought the hospital discharge planners, and you'll see why this is important in a minute, in a room. They never knew each other from the different hospital systems, never mind even knowing the community. I would challenge you to think about that in your own respective communities. Have they ever come together? And then the question is, who convenes them? Because that's the real issue and an advantage I think government brings as being a convener. Not just a policymaker and a funder and a provider, but perhaps our most powerful role as a convener. So we convened these folks and we designed this model where we actually used a network of care, and that's a free service out there, you can Google, to link Donald with his care team, with our county staff, and his daughter, who was the dependent, and providing support in terms of Donald's dependency. And what was remarkable about this is that we incentivized Donald to try to take more care of himself at his home. Well, what came of that was that since 2009, Donald has not been readmitted to the hospital. We have kept him in his home. This has led for us, very importantly, culture change and thinking about our practice. And this is a key component for us in California, our community care initiative, coordinated care initiative, beginning to look at, well, how do we bring these different services together, evidence-based? How do we take resources we currently have and better align them with our managed care plans, with our providers, with our government resources, in a way that also helps and puts that person, Ted or Donald, in the middle, so we begin to really understand. And then how do we provide them the right technology, which we're trying to solve here, so we can communicate? Because believe it or not, for the most part, we're still doing this the old-fashioned way. Could you imagine the day that we have in our Android phones the ability to share freely the information around Donald, like a hospital does right now with their patients, but to do that more broadly? Because despite the fact that we don't have that today, we were able to reduce the hospital readmission rate from about 21% to 12%, thereabouts. It's been remarkable. The net cost savings have been in the millions. This success, this transformation, led San Diego to receive just this January the largest CMS award for 21,000 Medicare fee-for-service clients on care coordination. And we're doing it with 13 hospitals. They've discovered that their next best friend is social services. Why? Because actually, I think we're good people and they like us, but because January 1st, there's penalties to hospitals for readmissions, preventable hospital readmissions. So this is our time now, with their undivided attention, to showcase why this matters in creating these kind of care teams and why we need the type of technology and interoperability so we can even do better than 12%, because we think we could actually bring it down to 6%. This is remarkable because we're talking about a large population of people we're going to be working over the next 5 years as a demonstration that was actually as a payment reform demonstration that will change the way that CMS, if we can demonstrate these results, will reimburse providers on Medicare, which will incentivize the integration with social services. This is big. So what's exciting for us is that what we learned from this is that all what we've been talking about, culture change, it's not the different plugs and wires. They're important. They're enablers. It's relationships. And when I talk to my counterparts and saying, you know, have you worked with your medical society, with all your physician groups? Have you worked with your hospitals? You know, it's challenging because you have to put yourself out there pretty much as a convener and take on a lot of the criticism, being government, on what you don't control necessarily at the local level sometimes, like Medicaid expansion, which we're also doing in our state. But more importantly is trying to find out, how do we really create this accountable care community concept that we're talking about? Everyone has accountability. It's not accountable care organizations, which is right now the big thrust. It's the accountable care community. We all have a role. I will tell you this, that in San Diego, but I think this is true in a lot of communities, we are resource rich, innovation poor. We are discovering more and more ideas of how to have things come together. And that is why we're here and we're very involved with the interoperability, because we absolutely need this platform for us to really achieve the aims of this 10-year plan we call Live Well San Diego. So for culture change, what we've been able to do is make this not the Health and Human Service Agency. We're working with all the different groups and departments in the county government, and as you can see, all the different sectors. Every one of these sectors you've seen listed here. We're working with 54,000 volunteers across hundreds of different faith communities. We're working with all of our hospital partners. We're creating this kind of collective impact, which I think many of you have heard, by bringing these different sectors. And what's now creating a challenge for us is they all want to play. But how do we share the data? How do we begin to share now beyond the walls of Health and Human Services, but how do we share it with a nonprofit organization? So we're still trying to win between sharing data between child welfare and probation and the courts, right? We got to go beyond that. So what we're putting out here is something pretty audacious, to say that we're hoping to use NEAM and the permissions and working with our attorneys, who are our friends, to allow us a pathway where we can begin to share this. We happen to be a community, is a beacon community. We're the only one, I believe, in the West Coast, or clearly in California, where it's a health information exchange among hospitals. They've done it. It's called co-opetition. They're all competitors, but they're all cooperating and sharing data. So today in San Diego, if you end up on one side of the county of 4,200 square miles, you will be able to have your data shared from another hospital in the county. Well, if we can achieve that through the Office of National Coordinator for Health Information Exchange, I think we can do that for all our other programs. Here is the relationship building, and I think it was mentioned about horizontal integration. This is the space by which we live today. We have the health sector, we have the social service sector, we have all these different entities and providers and services, and we have to work with all of them. How do you develop a relationship? How do you create that type of horizontal integration? And again, one of the issues that continues to come up is, well, and you develop that relationship, how do you share data? How do you begin to deal with this very complexity of all these issues that have been laid out, whether it's privacy, it's models of practice, cost, still having some nonprofit organizations that don't have the type of interoperability within their own system, never mind communicating with others. But these are the issues we're grappling with. And sometimes they're so daunting, people just take a step back and say, it's not worth pursuing, it's too complex. We're taking that different approach in San Diego. We're pursuing something called the Knowledge Integration Project. We think it's not just information exchange, which is important. It's data that's moving, that's going to then, this is now getting to the point made about interoperability. Daniel's point of, so now that we're sharing data across different entities, you have now a responsibility to take on data, creating new knowledge in how you provide your services. So we're attempting this model here in San Diego very broadly, learning from our good friends in Alameda, who's done some great work in this regard, learning from our friends in New York City, who have done some great regards. But we're taking it a step further, because what we're talking about is actually working on AB 109 as our star population, because I think we all know this is a population in California we all have, and these are folks that are multi-symptomatic, people that are on probation, and looking at how do we bring all the services coordinated with this population. And so we've been working with Gartner Consulting the last 2 years, and we'll be releasing pretty soon a significant procurement. We're going from the RFI idea to the RFP idea. We're moving forward on how do we begin to build this, knowing quite frankly that in creating this kind of enterprise service bus model, there's some simple things that would have huge impacts, bringing it down to the individual social workers. And that's why I love my job. I get to meet with the line staff who say, if we could just do a simple search and query, if we can just even get alert reminders, if the right hand just could know from the left hand the difference that would make in their impact and the people they serve, and improving their efficiency would be remarkable. Sometimes it's so complex, but there's simplicity that we can achieve that can have big gains for us. And this is a schematic, and we're happy to share our RFP once it becomes public in the weeks to follow, because it's important, I think, for all of us to learn from what states and counties and even local jurisdictions like Newark, New Jersey, cities are pursuing, and New York City are pursuing in this regard of electronic information exchange across health and social service programs and our community partners. So how do we measure this? That's very important. For me, I have to return to my board and say, for every public dollar we invest, tell us what the return on investment is. And this is very challenging, as we well know, in making investments in regards to technology. So what I talk about is how it's making a difference in the lives of the people we serve. Getting back to that triple aim of, if we want to become an area known for a healthier population, a safer population, one that achieves to keep children more in school than in home because of illness, one that keeps the Donald Ryans in their home, well, then we need to have the ability to have this information exchange for our workers and our community partners. And we have 900 nonprofit organizations that we contract with. Not profession that we're going to start with all 900. But that's where we want to go in the years to come, is the ability to have this broad connectivity. Now, just to end on, despite the fact that we don't have this today, we've been making some strides on this population-based approach. And I mentioned Newark, but there are communities out there that are also taking keen interest in what's happening in meetings like this here and what California is doing, because they need the interoperability backbone. Oregon and what they're doing with their coordinated care organizations are looking very closely in California about how we're laying out our architecture and interoperability. Places like Vermont, granted, it could fit in the corner part of my county, but never mind. I mean, it is still a sovereign state. They are looking at very progressive population-based approaches. But what's exciting to me is it always comes back, as Daniel said, is, but what is California doing? Just like we're rolling out our Covered California, our benefit exchange, our Medicaid expansion, coordinated care, our dual eligibility, child welfare reforms, behavioral health reforms, we need to have our interoperability systems reform. We need to get this before the legislature to say, without this tool, we won't be able to make greater strides than what we've done in San Diego. We've been able to reduce childhood obesity over a 5-year period. This has caught the attention of policymakers. We've been able to reduce heart disease and stroke in the region. All of this was because of this collective impact. And what I tell them is, can you imagine the day we have the technology tools and the permissions to share data across our partners of the greater strides we'll make in helping our population? So we continue to put progress, trends, positivity in front of our electeds to show this is the right direction. Not to profess that we have it all sorted out, but at least we know the general direction. And again, we know what our line staff are telling us of the tools they need in order to better serve the 750,000 San Diegans that my agency serves annually. So today we're talking about Live Well San Diego. Tomorrow it could be Live Well California. And not to push the San Diego platform, because I think we have a wonderful patchwork of our counties who are all working collaboratively together on the same concepts of improving health, the issue of safety, and economic vitality of our communities and families. And that's why we're here to be not only share a little bit of our of our journey, but actually to learn from one another. So I want to, again, convey my appreciation to Daniel and the team, Stewards of Change, and all of our state partners, and Shell, and everyone else who put this together. What we hope to achieve as a result of our participation is the commitment that we're going to further our knowledge integration program, our information exchange, and demonstrate how that makes an improvement in the lives of people through our service delivery system. So thank you very much. I probably have a question before drinks.
What would you say is the key to how you were able to get such great outcomes in a relatively quick time frame?
A lot of humility and appreciative listening, and not to be. I mean, candidly, it's empathetic and appreciative listening to what our line staff were telling us of what they needed, what our partners were telling us what we needed, and moving out of the way what we thought were the solutions. And humility of that we don't have all the knowledge on the solutions. And so that has allowed us to enlist and bring folks in as part of the problem solving for us, both within the county government family, but also our community partners. We needed to get away from the issue of not trusting, because if we weren't going to get even our employees, our labor groups, we've had to work with SEIU to be supportive of this. We have a large labor presence. But more important, if we couldn't win the hearts and minds of our employees to trust this process, it'd go nowhere. You know, if we built a great system, but it's not going to be fully optimized, what success really will that do? So candidly, that's what we've spent our time on, and that's the whole issue of building a relationship and the culture. It is the squishy stuff, but it's the most powerful stuff in terms of making sure you're building those relationships that then can get into some of the creative thought of how do you develop this type of system.
So what LiveWell is doing is pretty impressive, and I'm just wondering, it's unique in terms of what a county is doing, and what is the impetus, or what catalyzed this to begin, and what catalyzed you guys to take on these big challenges?
Thank you. And I would just say I don't think what I put up here is unique. The work that Don can be up here and talk about Alameda. There's a lot of communities doing this. I think we needed a battle cry. So what I would say is you need something to rally behind. For me, what I used as the battle cry that brought in all the different sectors, the slide I had of faith and business and government and leaders, was that 3 for 50, because it was easy to understand, yet pretty audacious in terms of how you're going to address chronic conditions, and knowing, quite frankly, that it's in the context of what I said earlier. In the presence of violence, you can't achieve health. So here we are talking about becoming completely trauma-informed as an organization, using a lot of culture approaches and changes to around safety in the workplace and how we work with the community, because we won't be able to achieve those health aims. But I think for us is really keeping something that the populace can understand, the media can understand, making your case compelling enough. And that has really what has galvanized a lot of our community. Great question.
Hi, so because we are California and not Vermont, do you see this kind of work that the appropriate level of should be the county, and that what we should have are other counties, not necessarily taking your model, like you said, other counties have different models, but that this kind of data linkage and systemic work should be done at the county level, and then hopefully eventually the different counties will find a way to share their systems across each other? Or is it ever a dream that this kind of system itself would be statewide?
The dream is nationwide.
Okay.
I think, and again, it's why not? If other nations have been able to do this, I used to have a slide to show that other nations, developing nations, spend more in social services and health, yet they have better health outcomes. But if other nations have been able to figure this out, why not us? With all the diversity and size that we have. But I think it's going to require to be at a local level with the partnership with the state. Absent that, we won't achieve the full aims. But real estate is local, and location matters. Well, healthcare is local. Location matters. It's building those relationships with those neighborhoods. We can't overlook that. But I think we have such a sheer size of this state. I forget how many states we could fit on the eastern border here, just in California. But that doesn't mean we can't develop all the different themes of population-based so they are working together. I mean, we have a unified eligibility system for the most part. I think, for our size state, can you imagine that, right? C4 and CalWorks. So, we have done things we should not lose sight of that are pretty remarkable in how we've streamlined and created that unification. In terms of this population-based approach, I think communities differ. And that's why healthcare is local. And you may need to take different approaches with your local populace. But let it be understood that the 3 for 50, that is constant across all communities.
Nick, thank you for being here and being part of the conversation. Since you have such experience in this regard, what one thing would you say we could do at the state that would further this along, further the conversation in the state, and get more counties to act like Alameda and San Diego and the other counties?
Well, I have homework to do. I need, and I've been doing it, I need to spend, and something we need to do, the one thing, I need to start by example, and I need to work with my own San Diego delegation, irrespective of what political party, to understand the nonpartisan issue in terms of what we're trying to do here with information exchange, interoperability, culture change on population-based. I would hope that we can do this at the local level and concurrently at the state level, so that our legislature and our governor and the administration could be looking at this as a real viable solution, and not just yet another technology ploy that costs money and so forth, but really as a transformation aspect of what we're going to do. I think there's great distraction right now, this year and next, but I think we ought to be focusing on that, and we're going to be enlisting, I think, not partners that never have come to the table historically around this type of solution, and I think that's going to be a benefit. The hospitals is what I'm thinking about, so that we can really have this collective impact conversation and not point fingers on whose responsibility it is, but how do we begin to share the data and the accountability in driving better health and wellness for the region. So it will start with, I think, our electeds to understand that this is important, and that's going to take some time.